Good morning, everyone. I wish you a warm welcome to the second day of our PRC seminar here in Oslo. On behalf of the PRC organization here, this is our second day of our two-day seminar. My name is Marianne Jernstad, and I work at the PRC Research Center as a researcher. However, before I introduce the first speaker, I have a few housekeeping rules, a little bit different from yesterday. First, I will point to the Mentimeter, which will be the first thing that pops up on the screen today. And while we wait for that and for you, and I urge you to answer to the Mentimeter as soon as possible, I will devote a few words to the chat. Yesterday we had chat questions after each speaker. Today we will save the chats for the expert discussions a little later today. So I don't know if the Mentimeter has popped up yet, and if you can see that on your screens. Just a second. Here it is. Please take a little while to look at the questions and decide which one you prefer. Here I see some people are active. Just wait a little longer before I introduce the first speaker. Okay, I think we have to proceed. Then it's my pleasure to introduce the first speaker, Professor Stein Kaasa, who is the head of the Department of Oncology and Palliative Care at Oslo University Hospital and the director of PRC. Stein.
Thank you, Marianne. It's good to be here. Good morning, everyone. Here we are again from the Norwegian Cancer Society Science Center. And we are live from Oslo, and it's great to see that so many participants are with us. So if I get the first slide. So I will talk about barriers and solutions for implementation of patient-centered care. So these are some experiences from our work the last couple of years, and also from an EU application. I will come back to that in somewhat more detail. And this is not one group or one man or one woman considerations. This is something which has been evolved, at least from my side and around me, and around in Norway and in Europe and worldwide. So just to start with, within medicine today, we have a lot of emphasis on personalized medicine, or now the word precision medicine is used much more. And if you go around and look into what is actually the content of precision medicine or personalized medicine, is primarily a biophysiological focus on it. So some sort of rhetoric question is, how can you deliver patient-centered or personalized or precision medicine without talking to the patient and asking the patient. So palliative care and patient-centered care, in my mind, these two headings are pretty similar, but not identical. So patient-centered care constitutes palliative care, which I think it's important to underline is much more than end-of-life care. However, if you go out on the street and ask about what is palliative care, I think most people will think that it is primarily end-of-life care. Palliative care, early integration, when and how. Supportive care also is a part of patient-centered care. It contributes to optimal anti-cancer care and a lot of other also effects. And survivorship care, which focuses on the patients after and during anti-cancer care. And that is also, in my mind, patient-centered care. So the umbrella terminology we may want to use in the future is patient-centered care. So we're talking about two paradigms, and that was what I tried to focus on just during the beginning. So you have tumor-centered care and you have patient-centered care. And I believe that it is extremely logical to integrate these two approaches. On the one side, focus on the cancer, and that's what the patients are expecting and the society are expecting. But the patients and the society are also expecting that we are focusing on the patient with the tumor. In other words, if you use biophysiological terminology, the host. But it is difficult. And why is it so difficult? Well, so where are we today? Palliative care, patient-centered care improve the care ratio and its prolonged life. It is cost-effective, and it asked for by the patients. And there are series of randomized studies showing that it is effective. As I said here, it improves symptoms, it improves patient satisfaction, family satisfaction, it is cost-effective, etc. Then I think it was okay to see actually in the post this just a couple of minutes ago that you didn't focus on that you need more randomized studies. You focused that you need something related to awareness, you need to address the gatekeepers, and you need to have some sort of implementation strategy. So I will come back to that. So I totally agree actually in that poll. Maybe we don't need that many more studies showing the effectiveness of patient-centered care or palliative care. And it is also a lot of recommendations around, but patient-centered care and palliative care, in my terminology and the way I read the literature and the way I understand the healthcare system, is that it is not implemented. Despite that the new WHO definition is not new anymore, it came in 2002, it defined palliative care, it should be implemented early in the disease trajectory. In 2014, World Health Assembly resolution followed up exactly the same. And major cancer organizations like ESMO and ASCO have repetitively recommended integration. So we have the randomized studies showing that it works, high quality studies published in high quality journals. We have the recommendations from the healthcare authorities, but I don't believe that it is fully integrated. So, but we see some variations between countries. Is it totally integrated into the healthcare system any place in the world? Probably not. Then it is reasonable to ask what are the determinants or barriers for implementing palliative care into mainstream healthcare, and what are possible solutions? I think one aspect is to understand the social determinants. So one important social determinant in my consideration is that we hear and we know that a lot of resources is put into improve the cure rate. And that's totally correct. I mean, I think that's a right priority, but it shouldn't be the only priority. So it shouldn't be that when you put a lot of resources into cure the patients and or to prolong life, you need to also give some priority to quality of life, to the family, to the patient living with the disease. So I believe it's a major challenge how to balance this message from the research institutions, from the doctors, from the nurses, socially. So, and then how to balance the message also during education, because it's no doubt that it is the cure, it's to prolong life, what students mainly are educated about. And we hear that in medical school, and it's probably also the same in nursing school and other educations. So again, how to balance this message and how to balance the resources economically. Do we need incentives, for example, for patient-centered care and palliative care, which are stronger and which can, in a way, balance the incentives which we see when we are giving incentives, economical and social incentives to cure and or to prolong life. So I believe, and we believe, that more than recommendations and resolutions are needed. Marianne talked a little bit about that, or quite a lot about that yesterday. So I believe that we need policy challenges, or we need to understand the policy challenges. We need to look into resource allocations. We need to look into how do the healthcare policymakers are asking for benchmarking about patient-centered care and palliative care. And we need to look into how healthcare authorities and policy makers are asking for palliative care, patient-centered care, survivorship care integrated into, for example, the cancer care guidelines. Now it's quite often an add-on and or it's a separate guideline, which is not integrated into, for example, the guideline for curative and life-prolonging prostate cancer or pancreatic cancer. And then we also need commercial incentives. So I believe that we need to collaborate with the pharmaceutical industry. And I believe also that the policy makers need to have a stronger and a more clear voice towards the pharmaceutical industry, asking for patient-centered care and palliative care incorporated as outcomes and as a basic understanding when they are doing studies, when they are asking for licensing of new drugs or other new technologies. We need to reduce the intensives for intensive end-of-life care. In other words, futile anti-cancer treatments towards end of life. We could easily have negative incentives, saying that you get some sort of deduction from the economical incentives if you treat patients with anti-cancer treatments the last 2, 3, 4, 5, 6 weeks. How long and how that can be discussed, but I think the mechanism we should discuss. And then we also need to look into the marketing, as I already talked about. Cancer can be cured, that's fine, but until all cancers are cured, we need to care for the patients with cancer. So, and then we have some healthcare challenges. Healthcare is fragmented, and we have fragmented planning and coordination. And that gives rise to inefficient use of healthcare resources. So with a better planning, and I believe that palliative care should be an active part of that planning. It hinders collaboration and teamwork between healthcare providers. We need to look into collaboration between the people who are focusing primarily on the anti-cancer treatment, and that's fine. That's the way it should be. But we also need to have the palliative care specialists, the survivorship specialists work together with the anti-cancer care specialists. And it is not cost effective to have a fragmented system. And it does not facilitate ethical, cultural, and other value conversations in the care team. So the challenge, we need some radical new approaches to improve supportive, palliative, survivorship, and end-of-life care. We need to do it together with the cancer patients, together with the families, together with the communities, and together with the healthcare providers and the policymakers. So it shouldn't be a standalone initiative by the palliative care movement or by the patient-centered care movement. I believe that the palliative care organizations and the people working in palliative care need to take the lead, but not as an initiative standing alone and working by ourselves. So in an EU application where quite a few of you participated, we had some sort of comprehensive solution, and we have a development and implementation plan. So here there are two crucial words. One is to develop, and the other word is to implement. And you actually said that in the poll also. You actually said you need to do something about implementation. You need to understand the gatekeepers, and you need to understand the facilitators. So what we are proposing is to use a methodology of patient-centered care pathways or standardized care pathways. And these should be digital. And these pathways need to include the patient's voice. That means to include patient-reported outcome measures and patient-reported experiences. And within these pathways, we should also include a shared decision-making system, which I don't know exactly how it's going to look like. That's why it is still in a development phase. But there are lots of information in the literature. We just need to put it together and get it implemented. It sounds simple, but we have been working now for 30 years to implement palliative care into mainstream healthcare. So it's not done in a week. It's not done in a year. And but we need the time. And then we have a workflow. Define the final concept of the structure and content of the patient-centered care pathways. Configure it digitally. And evaluate economically. You need to make it cost-effective. You need to have a social understanding of it. And it needs to be also involving healthcare experts. Implement and validate. And then we need to be more proper, and we need to have a better plan with regard to implementation methodology and raise awareness for the patient-centered approach all over in the society, when we talk to politicians, etc. And then ensure efficient and effective leadership. And that's exactly what is also said in the poll. We need leadership, top down and bottom up. So that's why we have developed this implementation ladder. And it actually tells us, I won't go through it in detail. There are 3 levels of target institutions. It's the policymakers, it's the healthcare institutions, and it's the families, the patients, and the healthcare providers. So this new 3-step ladder, the implementation ladder, I hope that we can agree upon. This should be modified and it should be discussed. But let's see how we have enough information. We need to talk about how to implement palliative care into the healthcare system in Europe and worldwide. So thanks a lot to a lot of collaborators from here in Norway, from UK, Mary Fallon and Bran McCormick, from also from Edinburgh, Peter Hall, from Milano, Augusto Caraceni and his co-workers, from Belgium, Luc Delins and Jacobs, from Spain, Andres Cervantes, from UK, from Leeds, Gelena Velikova, from Copenhagen, Per Sjögren and Gina Kurita, from Belgium, again, from Germany, Karen Jordan, from Romania, Daniela Muscio. And then we also have on board, if we get funding for this, a small ICT company. And we have also been working with our Swiss colleagues from Accelopment. And we are also have included ESMO, EAPC, and ECPC. So this is some sort of team. And if we get funded, I want to do this independent upon the funding. So I want to do this as a PRC initiative for the next 5 years. You will hear me more about it, and we can discuss later today during the panel discussion how to bring it forward together. So thanks a lot. Sitt, du skal bli sittende.
Må jeg sitte hele tiden?
Ja.
Thank you, Svein, for a very inspiring and comprehensive talk. I'm sure this will give rise to the discussion in the expert session later today. Just one thing for the listeners. I urge you to pose questions in the chat, and please direct the questions to each of the panel members in the expert discussion. Thank you. It's my pleasure to introduce the next speaker, Professor Anne Jacobs, who works at the Department of Media and Communication in Brussels, Vrije University. She's a sociologist with high expertise and interest in digital technology, implementation and utility in relation to healthcare. Please, Anne.
Thank you very much. Thank you very much also for the invitation. Indeed, I'm a sociologist by training, and my field of expertise is in digital health and work solutions. So normally my team is working from the idea, from the concept of digitalization in the beginning. So the technology is not there yet. And then we have a living lab approach where we start from the current practices people are doing with technology or not, or without. And then we start in a very participatory way to engage all stakeholders, patients, but also healthcare professionals and other involved stakeholders to think about this future and how they would like this future to be, to have a real people-centered design kind of approach. And the important fact is that you iteratively also evaluate then these ideas, these concepts in different levels of maturity. And in the end, you get a kind of proof of concept of a technology that you can trial, you can evaluate on its impact, both economically and socially. But that's not the end of the story, of course. As we know, for several years now, there's this rise in awareness that you do not get automatically from something very nice in a project into the daily practice of people. And so it's shown that actually half of the innovations, clinical innovations, just fail. They do not get out of the lab, to say. And it takes, Stan was referring, like we're already thinking about this more than 30 years. Actually, on average, it takes 70 to 20 years to have an implementation of this kind of very new, fresh idea. So how can we speed it up? How can we improve the risk? That's where implementation science actually comes in. And there are already several frameworks available around in implementation science, like HP, Sirocco. So we have a starting point to work with. And I'm coming to tell you a case from a previous European project, PROACT, in which we actually, with our colleagues of us, did an assessment of how can we create a framework to support us in we are creating in this project a novel integrated care platform, a digital platform oriented at people with multiple chronic diseases, helping them in their self-management. But how can we transfer it beyond the trials that go on in Belgium and in Ireland towards other countries, towards other organizations? And so they came up with this simplified framework, which can be actually a tool to guide you when you want to start with a transferability exercise. And that's also what we did actually after the project. But let me first also give you an idea of this digital intervention that came out of this Living Lab research approach. So it's actually a platform where people can view their parameters, where they can answer questions, where they can have psychoeducation. And we also made it so that also they can add, if they want, their care network to communicate about their findings and have it in a very readable way to see. So that's the platform that we wanted to transfer to another organization, and that we tested it out. So we tested it out for more than half a year with 120 people in Belgium and in Ireland, and we learned a lot about for who is it effective and for who isn't it effective. An important thing that came out of our first study was the importance also of the triage service, which actually called people when their parameters were a bit worrisome and guided them also when they had problems in handling devices, etc. And actually, we learned in our study for our 65 plus participants, it was really helpful in giving them self-confidence and creating also this insight in their disease. So it was seen as a crucial factor in our platform. Now, after the PROACT project, we tried also in Ireland. There were transfer cases related in Ireland related to COVID follow-up, where it was very suitable for. But of course, I will focus on the transfer that we did in Belgium. And in Belgium, we transferred to a healthcare facility in primary care, where they really wanted to work multidisciplinary. It are all independent practitioners from different disciplines. And they wanted us to help us with their diabetes patients. And so they broadened also the age range that we actually developed the platform for. So how did it go? Of course, with the framework in mind, we knew that we needed to adapt the solution. So if you look back at the framework later, you could see that adaptability of the solution is really essential, that you think about what is necessary in this context to adapt in the solution. So here we adapted, of course, the questionnaires that they were really relevant for the disciplines that were using the tool. And we also added a secure additional application so that the healthcare professionals could communicate and take notes and exchange that between themselves, because that was not part of the platform. So we adapted part of the content of the platform to make it appropriate. And we also, in collaboration with the healthcare facility, they hired extra staff so that there was enough availability of resources to do the pilot, enroll the patients, educate the patients. And so we gave them a training how to do that, and then it was normally expected that they would do it by themselves. But as you can hear, of course, in my story, that didn't went as expected. Actually, the diabetes educators that were hired, especially to do this pilot, thought it was too much work actually for the payment that they got, and they stopped doing it, which they could because they are independent employed employees, so they could stop. And the one educator that tried to do it further said, like, it was still too difficult to handle all the things he needed to think about to enroll somebody. And so actually that was a very important lesson for us, because we focus so much on the usability and the ease of use for the participants, and the family, and just in using when the system was going, that we forgot actually also to work on the user friendliness of the installation part. So that's work now for us to do in our next project to mitigate. But there was also another factor which is in the model, and that's more process and organization related. And that's in the second quote here on the slide. And that's that the employees of this healthcare facility felt that it wasn't a participatory decision to do this, that this was really a top-down, which was also related to their culture in this organization. So that was not aligned to make this also a success. What did make and that actually they succeeded in having 12 patients as foreseen to do and learn also from them, it was actually the leadership of the coordinator. Her engagement was really very perseverance, and through that it actually went on until the end, and everybody was included, and issues were solved. What we do also learn about the solution specific part, it's that also the triage service, which was such a success in our first pilot, actually for the younger patients was actually a nuisance, that they actually experienced this as during work times, getting calls, it was not helpful. It was just annoying. So also we learned also about differentiating towards different patient populations. And in the end, because the solution wasn't easy to learn how to install yet, actually the self-efficacy of the employees, so on the individual level, actually went down, and they started to doubt in their own capabilities, which is absolutely not the goal. So we need to go back through the drawing board, and we will do in the Seuro project, where we will also do a much bigger trial also with partners in Sweden. And what we will also work on is that you can use this framework not only during the implementation phase, but also in advance. So as an organization, that you can use the pro-transfer tool to assess, like, are we ready? Are we ready on the different aspects? And if we are not ready yet, what can we do? So that's what we are working on, and we hope to make progress on in the next few years. So thank you very much for listening. And of course, I'm happy to discuss how this knowledge can be transferred to the digitalization of palliative care.
Thank you very much, Anne, for a very comprehensive presentation, focusing on major important issues related to implementation of technology and actually implementation of anything new at large. Then I would like to introduce our next speaker, which is Anne Tove Brenne, who is an oncologist and a researcher at the Norwegian University of Science and Technology in Trondheim. She will present a complex intervention conducted in several communities in the Trondheim area. Please.
Thank you for inviting me to share with you our experiences with the implementation of the intervention in the Orkdal model study. I have no conflict of interest to declare. The aim of this study was to develop and implement a standardized care pathway to integrate palliative care early into oncology care and improve coordination across care levels in a rural region of Norway. And this is the region. It's located west to Trondheim, and the driving time from Trondheim to the local Orkdal hospital is 45 minutes. The region has 46,000 inhabitants, and 13 municipalities participated in the project. And the local Orkdal hospital was located here. In 2012, an integrated cancer and palliative care outpatient clinic opened at Orkdal Hospital. And when the integrated clinic opened, the planning of this project started. And these are the actors in this project. We have the carers, the patients, and the volunteers. The volunteers worked at the integrated clinic. In community care, we had the general practitioners, the cancer coordinator working at system level in all the 13 municipalities, the home care nurses, the nursing homes, and next to the integrated clinic, a community care emergency inpatient ward was established. We have the hospital with the integrated oncology and palliative care outpatient clinic. A palliative care team at Orkdal Hospital was established. And we have an inpatient ward, and the internal medicine inpatient ward where we cooperated. And this is the intervention. The intervention was the development and implementation of a standardized care pathway consisting of several elements like system assessment, system treatment, multidisciplinarity, care of the carers, nurse checklists when change of place of care, description of content of consultations, referral criteria, and also care and treatment plan when the patient was dying. The intervention also had an educational plan consisting of education in how to use the standardized care pathway, and also teaching in acute oncology and in central elements in palliative care. And we also had an information strategy. And this is the timeline. The project planning started in 2013. Implementation started in 2014. And due to slower inclusion rates and longer overall survival than estimated of the patients, planning and inclusion of and follow-up was prolonged with 1 and 2 years respectively. The duration of the implementation was also prolonged until March 2018. And the prolongation is here in blue. This is a table showing the member of the multidisciplinary working group who developed the SCP. And I'm not going to go into detail. This is just to show you that there were far many more people from the specialist healthcare services than from community healthcare services in this working group. All these three people from the community health and care services, one GP, the local cancer coordinator, and one home care nurse, they were going to represent all the 13 municipalities. This is a table showing the bottlenecks and challenges that we identified when we started to work with this pathway. They are related to capacity and resources, coordination and responsibility, and also to competency. The implementation strategy that we used was identification of bottlenecks and challenges, as I just showed. We had an information plan. We involved healthcare providers early in the development process of the project. We had multidisciplinary project group meetings. Local process facilitators were appointed at every study site. We had this educational program focusing on how to use the standardized care pathway. And we also revised the pathway every year based on feedback. This is a table to show you that we identified 1,320 healthcare professionals to be working with cancer and palliative care in the region. 91% of these worked in community care. And as many as 767 of these 1,320 healthcare workers were nurse assistants. And these people, they were the target for the implementation strategy. So to our experiences, the implementation strategy was conducted as planned and was found to be agreeable and relevant. Healthcare professionals from all municipalities attended the educational sessions. GPs from 7 of 12 municipalities attended the educational sessions, and 37 process facilitators were recruited, 5 from hospital and 32 from community care. Organizational we experienced that there were organizational cultural differences between the care levels that included different perspectives on care and the purpose of an SCP. Still, a common SCP across care levels for palliative care patients was feasible to develop. A patient-centered focus was considered important for the actual fit of the intervention, and healthcare professionals reported increased competence, coordination, and quality of care for cancer patients in the region after the implementation. The network of resource nurses and decentralized education were considered important for the successful dissemination of the SCP. The degree of implementation success varied at different locations. Factors related to lack of success were suboptimal competence in palliative care, lack of process ownership, fear of giving one patient group priority, and limited involvement from the management. In addition, restricted funding and lack of an electronic SCP search function hampered the implementation. 50% reported that they applied symptom assessment tools 2 months after implementation start and 62% after 2.5 years. 80% used the SCP 2 months after and 28% after 2.5 years. For 49% of hospital admissions during the same period, relevant medical information was transferred the same day as discharge. And at 3 years, 5 out of 13 municipalities reported that they used the SCP nurse checklists. So the conclusion, the healthcare professionals experienced increased quality of cancer care if the standardized care pathway was used as intended. We experienced improvements of process outcomes, but found limited use of the standardized care pathway in clinical practice, and thus the conclusion is that the implementation strategy failed. Some personal thoughts after this study. What probably contributed negatively was that this was a large intervention with very many different elements which made it difficult to know what to focus on. Many different actors in many different municipalities were involved. The intervention was not pilot tested. And there was a change in leadership during the project period that limited involvement from the management. And there was a lack of ownership in community care, and community care felt that they were forced to give priority to cancer patients. The data I have presented here has recently been published in this paper, and this project has been funded by the Norwegian Foundation DAM for Health and Rehabilitation and the Norwegian Cancer Society, the Norwegian Directorate of Health, and the Norwegian Women's Public Health Association, Orkdal. Thank you.
Thank you very much for a very interesting presentation, Anne Tove. It's really a complex and complicated study to run. I know we're all aware of that, and it has involved many people at different healthcare levels. It's now my pleasure to start the discussion, the expert discussion. And the panel members are Stein Kåsa, Olav Dajani, who is mastering the chat today as well. also consists of the two other speakers, Anne Tove Brenne or Anne Jacobs. And we have the pleasure to welcome Per Sjøgren, Professor of Anesthesiology and Palliative Care for Copenhagen, as part of the expert panel. So I hope you're all with us. And I think maybe we should direct the first question or possibility to comment on what we've just heard to Per Sjøgren, since he has been working with these issues for several years, together with us and in Copenhagen with several studies. Per, welcome.
Thank you very much, Marianne. Can you hear me? Can you hear me?
Yes, we hear you.
Great. Yeah. I think it was very, very interesting session. And what I think immediately is the great divide between the RCTs and actually implementation studies. And I can allude to Stein's talk, and I have an uncertainty about the number of RCTs carried out in cancer care. It is not that big. We have about, to my knowledge, more than 10 RCTs in this area, and they are done in different environments, in different conditions. And the question is basically, is it about integration of patient-centered care and tumor care? I think it is a big question if it is integration studies. Some of the studies are investigating early intervention as a specific component of these integration studies. So looking at the RCTs, I think the knowledge are still sparse. And in my mind, I think it is questionable if symptom relief, for instance, which is one of the primary causes for patient-centered care, is enlightened enough. I think what we have is emerging evidence that quality of life is improved by this study. But the problem in my mind is, do we have enough knowledge from RCT? Should we stop making RCTs in this area? I think that's questionable, and I did direct this question primarily to Stein.
I don't think we should stop. I think we still can conduct clinical trials. I agree with you that we need to look into the methodology we have applied. Concerning, for example, using pain as an example, I think we have enough knowledge. Then you can go to the literature on pain and pain interventions. So if you do a pain intervention following the guidelines, the 3 or 2-step ladder, etc., you will improve cancer pain. But my view has changed somewhat the last 5 to 10 years, and I think it showed repetitively, as Anne Tove also just showed in the Orkdal study, that we are not able to bring maybe some fragments, but we're not able to really integrate palliative care and patient-centered care into mainstream cancer care or mainstream healthcare as such. So the question is, what type of designs and studies do we need to figure out whether it works? And in my mind, I think we need implementation science studies.
I have a comment related to that, actually, because you proposed in your presentation, Stein, to use standardized care pathways or patient-centered care pathways as one mean to integrate palliative care and oncology care or anti-cancer care. And there is one question here to you, primarily. Thank you for the nice presentation. I totally agree such pathways would improve patient care and quality of life. I was wondering, which prompts would you recommend to include as part of the pathways?
Well, I think that's an open, I mean, that's something we need to look into. I think it should be, if we are making the pathways digital, the communication with the patients should be digital. So we need some sort of digital methodology. And I think we know pretty much what are the 10 or 15 most important domains we should include. That's exactly what you find in the FACT system, you find it in the EORTC system, you find it in the ESAS, etc., etc. So we need to develop a computer-based methodology, and there are several out there, and we have one methodology and others have others. So I think in general, it should be implemented, it should be used, and the big challenge is not to get the patients to answer the patient-reported outcome measures. The big challenge is to incorporate it into the clinical decision-making process, even in palliative care, and even in nurses working in palliative care.
Thank you, Stein. And actually, in relation to that, when it comes to implementation, there is another very good question to Anne Jacobs. Your project and solution seems very important, but I wonder, have you managed to integrate the solution into the electronic medical records of the different institutions? Or is the solution only available from the app?
Yeah, we know that's still the big bottleneck in this project that wasn't foreseen. But I think also with the plan and the vision that we have on the digital palliative care part, that is actually a basic assumption that this should be realized, that it is indeed integrated in the hospitals or healthcare facilities in their electronic digital systems. But of course, yeah, in such a project environment, you can't solve everything at one moment in time. So it is pieced, but it is indeed a very good remark. That is for the healthcare professionals, the reason why they are not that much engaged with the data themselves. But we saw actually that they found a hack for that. So patients found a hack. They just brought their data and showed it during the consult, and that was already very helpful. Also, not overloading the GP, for example, with daily monitoring, because that's another complaint on self-management and telemonitoring, the data overload, of course. So it's not the ideal solution. It's, I think, an in-between stage. But I think if you can foresee to avoid it, it's a big thing to do. So integrate it immediately into the existing systems.
Thank you, Anne. Stein has a comment before I proceed with the rest of this question.
Yeah, I wonder, Anne, whether we are in a situation right now that it should be mandatory for the next coming up projects, that the patient-reported outcome measures need to be available in the same way as, for example, imaging systems are available on the working platform of the doctor. The software, for example, guiding chemotherapy is available, etc., etc. So I wonder whether, in order to really implement it, that it should be mandatory, that it is actually accessible in order to have a true possibility to implement it into the decision-making process. I would like to hear your comments on it.
I think that's a good way to proceed. I know in Belgium, for example, the software packages for GPs have several requirements they need to do, and that actually brings the development of the software further in a direction that's in line with the vision of digitalization of the government. So it has impact, of course, if you can get such a policy top-down built into the software that's needed to be updated. So I think that's an avenue that could be fruitful. But of course, that means also, lobbying and policy change. And that's most of the time in Europe on a local level. So you also have very different systems. So that's also the big challenge. That's also why in many projects they are not connecting to the existing healthcare systems because there's such a variety. And also their standardization and interoperability are the big issue that you need to check upfront.
But that is And that is step one on our implementation ladder. You are saying that you need to approach the policymakers when you are starting an implementation project. So we need to start on step one.
Yes, sure.
But there is
But
more
it's
to
not
this than,
but
sorry.
it's not easy to, and it's not easy realized, of course. It's an ongoing process most of the time. It's not something you first just can solve. Most of the time it's going in parallel with the innovation and with the solution you try to manage, because you're trying to solve many problems at the same time.
But even if you have the policymakers on board, there are more implications to this. And the last part of this question was highly relevant as well, because it addresses whether you and your team have investigated or thought about how to investigate the barriers and facilitators for implementation among healthcare workers at the different institutions. And I mean, that's always difficult. It's a big challenge, implementing something new. Do you have any? Still sort of talking about the electronic solutions or digital?
Yeah. For me, it still also comes down to looking at how people are currently, what are their current practices. So finding the pains and how you actually solve those pains with your new intervention, so that you can also communicate that in a better way. And the assessment of those pains, that's also this participatory process. And you saw in my example, we try to skip that because it takes time, it's energy, but it also creates failure if you try to skip that.
A crucial thing to do in any implementation project. I mean, one tends to think that this goes well, you know, we have planned it so well, but it has to be a lot of preparatory work over and over and over again. And I think maybe Anne Tove envisioned some of that in the Orkdal project. Do you have any comments related to these difficulties of implementation at various healthcare levels, Anne Tove?
Yes, can you hear me? Yeah.
Yes.
Yes, I totally agree with you. And in regard to the first questions that were asked before the session today, what is most important for implementation? I will say that leadership is very, very important. In our project, there were several different organizations and 13 different municipalities, and also the hospital. And so there were very many leaders involved, and the involvement from the leaders were different from the different organizations. And then there is another thing that we also experienced from the Orkdal project, and that is the time aspect. I think you have to realize that to implement such a complex intervention, it takes time. So you have to be a little patient, and you have to adjust the implementation strategy while you are implementing. And then there is another aspect as well, and that is how to measure the effect of the implementation and the implementation strategy. Because in the Orkdal model, we asked the healthcare personnel if they used the pathway or not. But maybe we should have measured the effect also in different ways.
I think you address a lot of interesting and complicated points, actually. And I think all researchers are over-optimistic when it comes to setting a time frame from any project and any study. So I think you have, maybe I should ask Per before we proceed. Do you have any comments, Per? Because you've been involved in quite a few complex studies in Denmark, like the DOMUS study and others.
Yes, and I think they are absolutely not implemented. The DOMO study was a huge study we made for several years, and actually it didn't had a very good outcome on the primary variables in patients, but it had a very pronounced effect on the relatives, which was very interesting, as we had a dyadic intervention. for patients and relatives. But what I think is a burning issue here, and maybe a black box, is actually what we talk about all the time, and it's also a question to Anne Tove, is the leadership. We should in some way in implementation challenge the leaders. Who are the leaders? What are their background? Is there a disproportionate relationship between the knowledge of the leaders and the scientists who are making all these interventions? I think this is a huge issue and maybe too huge for this discussion, but I think it is a kind of black box. We're talking about it all the time, but actually we have, I think we have a black box there that we have to look into if we want to implement research, because I think my studies here have no big effect on the leaders whatsoever. And I was quite disappointed to hear Anne Jacobs' remark about it take 15 to 20 years to implement something. But anyway, we do the research, and if it's massive, the findings are massive enough, we may have some of the studies implemented or parts of the studies implemented, but it's very, very up to the black box, the leaders in my mind.
Thank you, Per. And I think this corresponds quite well to the three-step ladder that Stein showed, because we don't have to forget top down and bottom down. I mean, the healthcare providers who are actually going to do the implementation, to perform it on a daily basis, have to be part of the implementation process as well. But Stein, you had a comment?
Yeah, I have two comments. One is related to leadership. I think you need to approach leaders at all three levels or at all three steps. You need to do it at the policy level, you need to do it at a healthcare level, and you need to do it at a patient and family member level, because they are leaders at all these levels. Then I have a comment with regard to outcomes in implementation studies. I've changed my perspective during the work during the last couple of years, when I have been getting myself into implementation science technology, because I think we were thinking wrong, Anne Tove, when we planned the Orkdal study, and maybe you can reflect upon that as well, Per, because we are measuring outcomes on a patient level or a family level. That's fine. But I think in an implementation study, you should measure whether what you want to implement, whether it is implemented. So that should be the primary outcome, not whether it has an effect on the patients and or the family members. It might sound somewhat awkward for us who are used to think about patient outcomes. So this is where I am right now.
Thank you, Stein. Any comments from the experts related to Stein's comments?
Yes, sorry. Oh, yes, Stein, I think that's a really great comment. And I also think that this indeed what with ProTransfer tool, we are trying to make an instrument that you at the beginning, before you transfer, but also during transfer, you fill in with different persons in your organization to keep track about the different levels of implementation and how you take care of it. So you also have a kind of process evaluation after your implementation, because it's not about outcomes, it's also about process.
Thank you. I think there is time for a few more questions from the chat. There is one actually directed to Stein Kaasa, but I think there may be others who may be willing or interested in answering to that. Are patients also gatekeepers? Early in the disease, patients often protest a referral to palliative care. Making the patients demand, in quotation mark, a referral from the treating doctor by informing and educating them on the benefit of early palliative care could increase referral rates. How should we go about that? And would that be an important or a correct approach? Anyone? Per?
Okay, I'll try to embark on that question, and Pierre can follow up. I think that patients in one perspective might be gatekeepers. In another, I'm not sure whether it's correct to call them gatekeepers, but from a technical point of view, yes, they are gatekeepers. But I think we need to ask ourselves, why are they gatekeepers if that's the situation? I think there are at least two major drivers. One is that people want to live as long and as good as possible. So if palliative care is in their minds equal to end-of-life care, they don't want to be referred to end-of-life care when they at the same time want to be cured and live as long as possible. So that's one aspect to it. Another aspect to it is that patients are probably taught by the healthcare providers that they should be gatekeepers, which fits well with they want to live as long as possible. So then we need to address, what do we actually want to implement? What do we want to implement?
And in this respect, I think it's important for healthcare providers to sort of reduce their professional autonomy and see that everyone is not supposed to perform or deliver specialized palliative care. Referral and collaboration is good. And we need to convey that message to the patients that palliative care alongside tumor-centered care is a benefit for everyone. There is one more question in the chat.
I'll just go to the one that says, we don't have patient organizations and NGOs pushing the agenda in public. Any possible solutions? This was to Stein. Or Per.
Not me.
Okay, Per.
I had a problem in hearing the last question, and also a part of this, but it was something with the patients' organization pushing the agenda forward.
We don't have NGOs and patient organizations in the palliative care like you have in breast cancer and other. So what would be a solution to pushing it public?
Well, I think we should, to some extent, in Denmark and probably also in Norway, have the Cancer Society also pushing the palliative care agenda forward. I think at least in this country, it is pushed forward to a higher and higher degree from that society. But in general, yes, this is not pushed forward by these organizations. That's true. And I think it's a public responsibility to look at the resources to palliative care. It will always be a public responsibility. Also alluding to Marianne's talk yesterday about the determinants, the commercial determinants. So I think, and we know that very, very little means go to palliative care also in research. But I think the Cancer Society are pushing this agenda forward to a higher degree these days than before.
Now there are more questions coming into the chat. There is one here, really enjoying the session and discussion. And to the panel, are we critical enough assessing the potential implementation of research when we are developing clinical trials? I think maybe you could provide a comment on that too, Per, because you have been involved in so many trials, some that have worked well and some that have not. And do you think this is related to the definition of the outcomes?
Well, I think Stein had a very good point before, but I think the outcomes should be combined. Of course, we are interested in patient outcomes. Still, we're also interested in the family outcomes generally, the closest relative, etc., etc. But of course, we are also interested in implementing our research, and I think an assessment of that would be a very, very interesting way forward. But I think there are several outcomes in play that is needed in the future?
I think that there are several aspects to it. I think when we are running a clinical study, that should also be considered as an implementation. So we should learn from for example, the medical industry. They are running phase 4 studies after they have been licensed or got the possibility to license drugs. And the main reason for running these phase 4 studies is actually implementation. So studies have some sort of implementation potential, but it stops when the study stops. So you need to have a follow-up after you stop the study to continue the implementation. So this is some sort of continuous process. And again, learn from not only medical industry, learn from other types of industries, car industry, etc., etc. Marketing works. And we saw yesterday during the poll that marketing works because Vicky marketed muscle, others marketed weight, and no one marketed patient-reported outcome measures, which is similar to asking the patients about appetite, etc. And no one in the poll actually ranked that as important. So I think we had a snapshot of marketing yesterday. It works.
Well, I guess that's why the publishing industry does so well, you know. There is one question about social diversities to Anne Tove. The SEP looks great. I wonder, do you know if there is a difference in uptake and outcome across socioeconomic and ethnic diversity? I guess that may be difficult to answer at sort of the individual patient level at this stage, but do you have any comments related to this?
No, yes, no, I'm sorry, I don't know about ethnical diversity because this region, that was a rural region in Norway, so most of the participants were Norwegians. And what we saw was that this was we had a control region, and we saw a difference between the participants in the control region and the intervention region when it comes to education. But that didn't influence on the result. But I would like to comment on this, how to measure the outcomes, because my experience from the Orkdal model study is the same as you have been pointing to. It's difficult to measure patient-related or clinical outcomes. But what we experience from our study, and that goes on also after the study ended, that this intervention really works. And I think that maybe if we have measured the effect of it later, maybe we would have got another result. How you measure the effect of the intervention, that's very important.
I agree with you. I couldn't agree more, actually. And then I think this leads us to the last question, at least the last question I have on top of my chat here. It's directed to Stein. Interesting thought about the use of outcomes. Perhaps you could elaborate a little bit, if I understood it right, and I think maybe you could just elaborate on whether you mean to first test whether the implementation succeeds, and then in the next step, measure if patients and families have beneficial experiences with it, or do you mean to sort of collapse that into the same study? That could be a challenging closing remark.
Yeah, and it's a challenging question. I think that the primary outcomes in an intervention study should be process outcomes. And you should assess whether the intervention is integrated into the decision-making processes within the healthcare system. That should probably be the primary, secondary, and tertiary outcomes, those types of outcomes. The main reason why I'm afraid of using symptoms or functions as outcomes is the heterogeneity of the patient population. So you might hide a possible effect on different type of patient-reported outcomes, for example, if you or when you have a very heterogeneous population. And that's something we actually learned in our study we started in 1993 in Trondheim. And we showed an effect on population level, and we didn't show any effect neither on quality of life or on symptoms. And I think, and we discussed that actually in that JCO paper, that the primary reason was probably the heterogeneity of the population. So I would be very careful to have that upfront as outcomes.
Thank you, Stein. Famous last words. I think we have to close this session. I would like to express my gratitude to the panel, extended by Per Sjøgren from Denmark, and wish you welcome back in 10 minutes after a coffee break. Thank you.
I welcome you all to the PRC Congress in Aarhus in 2022. The PRC is a palliative care research center situated in Oslo and led by Professor Stein Kasa.
We are very much looking forward to have this conference placed here in Aarhus and to meet again after years of online conferences.
The seminar focuses on collaboration, and we're bringing in researchers from all over the globe to enhance collaboration in palliative care research.
The conference is for everyone interested and working with palliative care, for all professionals, researchers, professionals working together with the patients in palliative care.
Aarhus University Hospital is one of the largest and most modern hospitals in Northern Europe, and we have more than 9,000 team members.
The conference will be held here in the very center of Aarhus, next to the famous art museum, the town hall, the old town, and outside Aarhus you'll find sea, the woods and the harbor.
Aarhus is a wonderful city, and I think it will be a great experience to keep the Congress in this wonderful environment and to have a great time here.
Today, Aarhus is a very young city with very many students living here. It's a vibrant, lively city with plenty of bars and restaurants and a very cozy atmosphere.
I'm always very, very excited about these congresses, and I know there's always new information, new studies, and it's also an opportunity to meet new people and especially young researchers within the field.
I look forward to meeting colleagues from all over the world to hear about new results in palliative care research, but also to share our results here from Aarhus University Hospital.
We are very much looking forward to seeing you at the PRC conference here in Aarhus.
Welcome back, everyone. Now there is a very short session presenting two of the highest rated abstracts today. The first one is by Claudia Fischer, a researcher in health economics at the University of Vienna, Austria. And she will talk about methodological aspects of economic evaluations in the palliative and end-of-life care setting. Claudia.
Good afternoon. My name is Claudia Fischer and I'm a postdoc researcher at the Medical University of Vienna, and I'm happy to present you today the results of a systematic review I have conducted along with my co-authors, which I would like to acknowledge at this point. The systematic review focuses on methodological aspects of economic evaluations conducted in a palliative and end-of-life care settings. Some background information first. Well, in light of the constrained resources and at the same time the growing palliative and end-of-life care patient population, effective and efficient resource allocation is of great importance. Nevertheless, the economic component has often been overlooked in palliative and end-of-life care studies, which is leaving several unanswered questions for the quality assurance, monitoring, funding and evaluation. Further, it can be observed that palliative and end-of-life care research lacks common research guidance, and this holds as specific for health economic research. So this brings us to our objective, which is to identify and summarize information on methodological challenges and potential solutions, as well as recommendations for conducting economic evaluations in the palliative and end-of-life care settings. This study has been conducted in course of the ILIV project. The ILIV project is a 4-year research project funded by the European Union Horizon 2020 program. And this project is a collaboration of 14 organizations from 13 countries. It aims to develop novel, evidence-based and sustainable interventions to relieve the symptoms and sufferings that occur at the end of life for patients with advanced chronic illnesses and their families. A specific digital medication tool to optimize medication management and the hospital volunteer training program are evaluated. Of both these interventions, the cost effectiveness will be assessed, and therefore also the findings of this systematic review will be incorporated. If you want to learn more about the ILIV project, check out the website, register to our newsletter, or find us on Twitter, LinkedIn or Facebook. But now back to the systematic review and an overview of the applied methodology. So the patient population we targeted at were adult palliative and end-of-life care patients in different settings, and the outcome of interest was defined as methodological aspects and recommendations for conducting economic evaluations in the palliative and end-of-life care settings. We included the studies in multiple languages, which were English, German, Dutch, French, and Spanish. Further, we included also multiple study types, which included systematic reviews, meta-analysis, narrative reviews, observational or interventional studies, editorial discussions, commentaries, economic guidelines, checklists, and qualitative study. The search period covered January 1999 until December 2019. Information sources were also covered, multiple ones like Medline, Embase, Cochrane Library, and NHS EE. The search strategy was developed in collaboration with an information specialist and was a tailored search string, including the mesh terms, free text words, and these were translated into the different databases searched. The study selection was taking place by 2 screening rounds and 2 independent reviewers. For the data extraction, we applied standardized data extraction forms. For the data synthesis, we conducted a narrative approach with thematic synthesis. For the quality appraisal, we used the quality appraisal tools for the respective study designs if they were applicable. And for the quality assurance, we followed the PRISMA guideline, also did the Prospero protocol registration. So moving to our results, our research strategy revealed 4,989 hits based on a database search, and we identified 28 additional studies by screening additional sources like the Gray literature search and reference search. After conducting the 2 review rounds, just in brief, we included 121 studies for the full data extraction, and the inter-rater reliability agreement was high with 97%. So now I would like to present you an overview of our findings. This is just a summary. So one aspect we identified was the target population. There, a challenge is that there's no objective way to identify end-of-life care patients, and one potential solution to overcome this would be to identify patients via care processes and patients themselves, refine the prognostic criteria models that diagnose professionals, for example, the surprise questionnaire. Regarding the setting and location, we found that there is restricted generalizability due to high care customization. And one potential solution for that would be that heterogeneous palliative care population is segmented into more homogeneous groups. For the study perspective, we found out that there is often a narrow hospital or payer or healthcare perspective applied, which provides potentially a biased picture of effects and costs. And for a valid cost reflection, one should include multiple and simultaneous service use assessment, which is often the case in the palliative care and end-of-life care setting. Further, a societal perspective should be adopted, and the application of 2 reference cases in cost-effectiveness planes is advised to satisfy the diverse information needs. Regarding the choice of health outcomes to use, there was also a huge discussion, and the main challenge is that it's currently unclear whether to give preference to generic or palliative and end-of-life care specific outcome measures. Also, there were potential solutions suggested in the literature. One could apply context-specific outcome measures or apply outcomes with a narrow focus on processes and which aim at the tested interventions. Further, it's advised to test well-established generic measures alongside with disease-specific ones and to include outcomes of the patient's environment too. Regarding the measurement of effectiveness, it's currently unclear whose proxy assessment is most reliable, and also here more research is needed, so the inclusion of proxy assessment of multiple stakeholders is advised in order to enable validations. Regarding the preference-based outcome measurement and evaluation, currently values are generated from the general population and not patients, and this is a potential problem, and one way to overcome this would be to explore values from, for example, care providers with a better insight on the relevance of certain capabilities. And last but not least, estimating resources and costs. So one challenge I want to name here was the assessment of palliative and end-of-life care family costs. So for example, the cost for home adaptations, they are currently not well understood, and one potential solution to overcome this problem would be to conduct longitudinal cost assessment over more disease trajectories to capture the fluctuating carrying cost, but also to consider the affected family network, which is at least the 3 closest, which includes at least the 3 closest individual of the patient. So this brings me to my conclusions. I can conclude that the current existing methods of economic evaluations are not entirely applicable in the palliative and end-of-life care settings. We identified multiple challenges, which include the problem with the accurate patient identification, the problem to differentiate interventions from the comprehensive standard care, the narrow perspective which is often taken, the limited generalizability and transferability of evidence, the ambiguity regarding the applicability of generic or setting-specific outcome measures, and the difficulties regarding the proxy assessment, valuation, and cost estimation. Nevertheless, the identified challenges may be tackled, for example, by applying binary reference cases, longitudinal assessment, considering costs of at least the 3 closest individuals. Further generic quality of life measures should be tested alongside with the disease-specific ones, not only for the patient, but also the affected environment. This was a very brief overview of the systematic review we conducted. I would like to thank you for your attention. In case you have any further questions, here you can see my email address stated. Please feel free to get in touch. And with this, I would like to wish you a very nice remaining seminar. Thank you.
Thank you, Claudia. This was interesting and quite a new area, at least for me. I have one question for you. So far, we haven't had any questions in the chat, so I urge people to ask questions about this good abstract presentation. What do you foresee as your next step following up on this literature review?
Yes, thank you. That is a very good question, because indeed we identified a lot of problems, but just could came up with a few suggestions. The next step, the next concrete step we want to do also in the course of the ILIF study is to see actually in the next systematic review what do studies currently do with these challenges we identified. So how do these challenges in applied economic evaluations are handled? So we're going to conduct a systematic review and check on these factors we identified and see do we find any information in these studies.
Overall goal to come up with a model for use in your hospital in palliative end-of-life care at general, or what? How do you foresee the perspectives related to that?
So if I understand right, you're asking me, okay, the implications, we try to develop some kind of framework and guidance and recommendations for future economic evaluations to see, okay, if you conduct a economic evaluation in this challenging palliative and end-of-life care settings, these are some methodological recommendations we came up with and which are useful to follow in order if you want to apply valid and reliable economic evaluations in the settings.
Thank you. It sounds challenging, actually, to me, at least to me. I think we have a problem that now the next speaker is still not on. So this means we'll have a long break. I'm sorry about that, but it cannot be helped. That was a live presentation. So if things change, we'll see what happens. Anyway, have a break, enjoy coffee, and stretch your legs. Thank you. Hello again, and welcome to new listeners or participants. I would now like to introduce our last section today, focusing on pain and neuropathic pain. We have three distinguished lecturers who will present today. The first is Marie Fallon, Chair of Palliative Medicine in Edinburgh and Honorary Consultant in Palliative Care at Western General Hospital in Edinburgh. She leads a large portfolio on multicenter trials, and today she will present their double-blind RCT. Please, Mary. Just one comment before I give the word to Marie. Questions will be answered during the expert panel session at the end of these three presentations. Mary.
Okay. Thank you very much indeed, Marianne, and thank you so much for the invitation to speak today. I'd like to present the results on the tanezumab, which is a monoclonal antibody for nerve growth factor for metastatic bone pain. So, as you know, bone is the most common site of metastasis, along with lung and liver. It's the most common type of difficult to control cancer pain. In 60 to 80% of patients, it's at least moderate to severe. We know it impacts significantly in physical function and quality of life. And the current treatment focuses on prevention of fractures, improvement of function via a multidisciplinary approach. And within that approach, clearly, when pain is uncontrolled, palliative radiotherapy remains the gold standard, along with other radioceuticals in certain situations. And there's the standard list here. When it comes to analgesics, we encounter challenges and have done for many years because opioids do not actually cope with adequate relief without significant side effects on many of the characteristics of bone pain, and I'll come to that shortly. So this is based on a paper we did about 10 years ago, where we were interested in looking at consecutive patients coming for palliative radiotherapy. And we were really interested in what were the differences between the background bone pain, the evoked pain, such as movement-related pain, and spontaneous pain at rest, which is thought to be driven by a neuropathic component. And of course, the outcome of all of this is, as we've said, very much reduced quality of life. So we looked at 50 consecutive patients coming for palliative radiotherapy because of uncontrolled bone pain. And just to summarize, you can see that the average number of breakthrough pain episodes a day was 4, but it ranged from 2 to 8. The severity of breakthrough pain episodes was on average 8 out of 10, but ranging from 4 to 9. And the interesting and important factors from the point of view of our challenges of finding analgesia is that the onset of breakthrough pain, you can see in the majority of patients, is a combination of unpredictable, comes on in less than 10 seconds, or between 10 seconds and 5 minutes. So this is from onset to peak. You can see that the majority of patients, the vast majority, this will happen in less than 5 minutes. Combining that with the fact that the duration of the breakthrough pain episode, again, in the majority of patients, is well under 15 minutes. So looking at the standard opioid type medications we'd use, even the faster acting opioids, you'll see that in the majority of patients, and we had in fact 50% had rapid onset and short duration, you'll see that the bone pain has come on, has peaked, and has resolved by 15 minutes. And standard opioid analgesia is obviously not going to be effective in these situations. So moving forwards, we clearly need to think of improved methods of bone pain relief. And looking at the pathophysiology of bone pain, I think one of the most important things to point out is that bone is very, very richly innervated. There's a very complex, dense network of nerve fibers within bone. So it's not just the periosteum, it's within the bone matrix. And this is key to the understanding. The other thing is, over the years, we've been targeting specific pain signaling or neurotransmitters. And this ranges from the classical anti-inflammatory drugs, sodium channel drugs, even NMDA antagonists. But I'll show you shortly how these are actually only very tiny parts of a jigsaw. And the challenge has been to try and understand this jigsaw of bone pathophysiology and how we can actually target more the key players in this rather than chip at the periphery. So here is where we're at currently. A significant amount of preclinical research established that when we actually have peripheral injury, so that includes a metastasis to bone, we actually have significant relief of something called nerve growth factor, okay? So nerve growth factor basically modulates pain signaling. When we're neonates and young, probably up to about the age of 2, nerve growth factor actually plays a role in normal development. Beyond the age of 2, it's not needed for normal development, and its role really is predominantly more in pathological mechanisms. The nerve growth factor binds to something called TrkA, and TrkA is tropomyosin receptor kinase A. And this is on all the peripheral nerve terminals of the nociceptors, and it's thought to be present on at least 80% of the nerve terminals in bone pain. And this nerve growth factor TrkA complex then initiates a whole cascade of signaling that actually upregulates both the local receptor activity in the peripheral nerves, but also in a number of very pro-nociceptive channels, such as TRPV1, sodium, calcium, potassium, etc. And you get an overall supersensitization of the receptor, of the TrkA receptor. And this, of course, transmits clinically to hyperalgesia and increased pain response due to the sensitization. And this complex undergoes something called retrograde transportation. So it goes to the dorsal root ganglia, also goes to the dorsal horn of the spinal cord, further up the spinal cord, and is also transmitted to the periphery. And here it really, really exaggerates the release of inflammatory mediators. And we have this intense inflammatory response to this complex of nerve growth factor, TrkA. As I've said, the result is we get a very significant hyperalgesia. And this goes some way to explain why bone pain can be so painful, number one, and number two, so tricky to actually control, because this hyperalgesia is what's very much behind the spontaneous pain at rest and the exaggerated pain on movement. So we can see here, really for the first time with the work in nerve growth factor, that we understand more the total cascade and the jigsaw of bone pain, rather than parts of it, whether that's inflammation, NMDA, sodium channels, TRPV1, etc. It really draws the story together, and it does seem to be a major part in that story. So a number of preclinical studies used anti-nerve growth factor agents. And this was in animal models of cancer-induced bone pain. And we do have a number of very good animal models. And it really inhibited this neuroma-like structures that form due to this interaction of nerve growth factor and the TRAC channel. And it very much reduced both the neuroma-like structures and also reduced the pain behavior in animal models of osteoarthritis and cancer-induced bone pain. Then subsequently, there's been a number of studies in osteoarthritis and low back pain using anti-nerve growth factor agents such as monoclonal antibodies, tanezumab, that was the subject of this study. And then there have been phase 2 studies in cancer-induced bone pain, one using intravenous tanezumab and the other actually using subcutaneous voranumab. And while the primary endpoints of these studies were negative, in exploratory analysis, there was definite signals of analgesic action, significant analgesic action in both pain and function. So given the strong preclinical case, the clinical work in osteoarthritis, and then the phase 2 work in cancer pain, in bone pain, Pfizer and Eli Lilly collaborated on a large multi-center study involving 15 countries, looking at the efficacy and safety of tanezumab in cancer-induced bone pain in patients who were receiving stable background opioid therapy. So I'm going to present the results. It was a phase 3 randomized double-blind placebo-controlled trial, and all patients were stable, both from the point of view of background oncological management and also from the point of view of background opioid management. The patients all had to have a diagnosis of active cancer having metastasized to bone or multiple myeloma. The average pain score had to be at least 5 out of 10, and the index, at the index bone site. And as I've said, other treatment had to be stable. Patients were randomized to receive either double-blind subcutaneous placebo or subcutaneous tanezumab, 20 milligrams every 8 weeks for 24 weeks. So that was 3 doses in all. And then there was a 24-week safety follow-up period after the treatment period of 24 weeks. The primary endpoint was the change in daily average pain intensity at the index bone site from baseline to week 8, and that was evaluated by analysis of covariance. Adverse events and pre-specified joint safety events, and these were also assessed. Now, just to mention at this point, in the osteoarthritis studies of tanezumab, there had been identified a subgroup of patients who were having intra-articular subchondral fractures. There was an independent adjudication of these via the FDA in these OA studies. And the exact pathogenesis wasn't clear, but it was thought that it was due to an accelerated osteoarthritis. And there were different theories around this. One of the theories being that in those patients who had good analgesia, they were in fact moving an awful lot more in quite distorted pathological joints. So that's just to explain the pre-specified joint safety. The demographics and characteristics, there's nothing unusual here. And most patients had, as you'd expect, either breast, prostate, or lung cancer. The mean duration since cancer diagnosis had been just about the 4-year point in both groups, active and placebo, and duration since diagnosis of bone metastasis was at the 2-year point in each group. Patients were stratified according to aggressiveness of disease and whether or not they were on active tumoricidal treatment. So efficacy, basically tanezumab 20 milligrams met the primary endpoint, demonstrated significantly greater improvement in daily average pain intensity at week 8 compared with placebo. And there were also significant differences in favor of tanezumab at weeks 1, 2, 4, and 6. Beyond week 8, the significance was lost, but the study wasn't actually powered to look at differences beyond week 8. I won't go into it now, but there were other interesting differences beyond week 8, although the study wasn't powered to look at significance, differences in function in particular and worse pain. Safety, there's nothing to report in safety in that it was as one would expect for this population of patients, and also the known side effect profile of tanezumab. There was no difference in deaths. There were more patients withdrew from the placebo arm than from the tanezumab arm. So to conclude, the study achieved the primary objective. It demonstrated superior analgesic efficacy of tanezumab 20 milligrams subcut versus matching placebo at 8 weeks. And differences past 8 weeks were not significant. Adverse effect profile was nothing unexpected. 2 patients in the active arm did have pathological fractures, while no patients in the control arm did. Overall, I think these data demonstrate the potential of a nerve growth factor antibody, whether it's tanezumab or another, to reduce pain caused by bone metastasis. And it will be interesting, obviously, to see the durability in a different study of different design. So thank you very much.
So much, Mary, for a very interesting and comprehensive talk presenting new results. We just have to proceed to the next speaker, Frank van Haren, who is an anesthesiologist at Nijmegen in the Netherlands, pursuing a PhD. And he will present research on the treatment of peripheral cancer-induced neuropathic pain with capsaicin.
Hello, my name is Frank van Haren. I'm one of the anesthesiologists and pain physicians from the Radboud UMC Hospital in Nijmegen in the Netherlands. I want to talk to you about the research on chemotherapy-induced peripheral neuropathy. First of all, stating I have no conflicts of interest to report. I do some research on Qtenza, capsaicin, but it's all non-sponsored. I want to talk to you about CIPN. What is it? Why is it important? The current status of evidence, future research, including our focus on research in CIPN. Talking about CIPN, most of you know the phenomenon. It is peripheral neuropathy arising after chemotherapy, could also be during chemotherapy, but due to chemotherapy, by taxanes like paclitaxel, platinum substances, vinca alkaloids, and proteasome inhibitors, with a highly variable incidence due to the chemotherapy used. It's about 20% for vincristine, and up to 70–80% for paclitaxel and oxaliplatin. With increased survival of cancer also by chemotherapy comes an increased prevalence of CIPN, with for a lot of patients a decreased quality of life in the acute and chronic phase. Its presentation is highly variable. It has sensory, motor, and autonomic aspects with different onsets, acute versus chronic. This is especially well known for oxaliplatin. And it has sometimes phenomena of ghosting, which means that chemotherapy is already stopped, and after this, complaints keep on getting worse. The current status of evidence is scarce. There is increasing interest for treatment options, resulting also in ESMO guidelines in 2020 and ASCO guidelines in September of this year. But there remain few evidence-based options, especially for prevention, but also for treatment. So the ASCO guidelines and the ESMO guidelines, they have a somewhat different interpretation of the possibilities. Interesting, although, is that some of the authors have been busy with both. But looking at what they actually advise, they have a somewhat different approach. So for prevention, dose delaying, dose reduction, substitution, and stopping, so dose changing, is advised by both based on the complaints that are seen. No actual agents are recommended for the prevention. A lot of agents were studied in the industry, but none of them actually proved any significant improvement. ESMO advises non-medicinal approaches such as staying active, exercise, but also this is not entirely proven to be effective in preventing CIPN. For the treatment, both advise duloxetine. Duloxetine is an anti-neuropathic drug, an antidepressant actually. It has a proven but small results, small effect on CIPN complaints when already experienced by the patient. One could consider other drugs, topical application of menthol or capsaicin, exercise, active acupuncture, spinal cord stimulations, only advised or considered by ESMO with scarce evidence. Some small articles on a possible effect, no RCTs, no definitive proof. So one could deduct some research directions. In the prediction, it could be interesting if all risk factors are known or others to be accounted for. Genetics could be interesting, such as single nucleotide variations implied by ASCO, pathophysiology in general by ESMO. And when talking about the diagnosis and even about changing chemotherapy doses, one should talk about the same problem. So is there a gold standard for diagnosing CIPN? Also, the ASCO and ESMO guidelines give some implications for this. Maybe new options, not previously studied. NCI, which is the National Cancer Institute Research Commission, has denoted exercise for the prevention an important subject to study. For the treatments, maybe other anti-neuropathic drugs, which now mostly have level 2C evidence, but also NCI implies duloxetine should be further studied. Capsaicin 8% patches, which is Qutenza, could be studied according to ESMO because of its results in non-chemotherapy-induced peripheral neuropathy, but maybe also other options or other evidence could be interesting. There are a few mentioned by ASCO and ESMO. Which brings me to our focus. We also studied the use of capsaicin in CIPN and the use of lidocaine. My colleague Sander van den Heuvel published a study in 2017 on the treatment of a few patients, and we have started including in a Lyon study, which is a RCT on the prevention, which has also led to a publication on the pharmacology in this matter, which I will elaborate on later. The determinants for treatment and follow-up is something we look at in quantitative matter by the means of interviewing neurologists, pain physicians, and oncologists. What are the main steps and their ideas on treating patients with these complaints? Starting with Qtenza, it's important that there's a recent Nobel Prize won by Professor David Julius on the discovery of receptors for temperature and the mechanism of action for capsaicin, the TRPV1 receptor, which is the transient receptor potential, and the V stands for vanilloid. There are other subtypes as seen in the figure on the right. TRPV1 is interesting in heat perception, so heat between up to 45 degrees, but also the working of chili, the experiencing of the burning sensation of chili. The latter is also captured in the Scoville rating scale, so Scoville heating units, SHU, which is 16 million for capsaicin, but all peppers are scored on this Scoville scale. In the Netherlands, we have Qtenza available, which is 8% capsaicin in a patch, but also 0.025 and 0.075% ointments for home use. An interesting study in this context is by Anand. They studied patients receiving Qtenza in CIPN complaints. Primary outcome is looking at regeneration and restoration, and it seems that intraepidermal and subepidermal nerve fibers somewhat seem to regenerate based on different receptor measurements, which could imply that there's disease modification, which is hugely interesting when one could not only treat but also cure the phenomenon. Secondarily, they also looked at pain and touch and evoked pain, impression of change, and they all improved, but really disease modification should be more interesting. Other studies, small studies, looked at purely at the pain, Hudson BPI also for the first study, Remnarin in 2016, which showed improvement in most patients, also for Hudson BPI. Filipchuk looked at the NRS changes also in relation to cumulative dose, and they made two groups, one for low sensitivity, experiencing only complaints in high doses, which had the group had a better pain reduction, but also less pain to start with, which could be some bias. Lemarak et al. Looked at chemotherapy and Qtenza in 28 patients, also effective. Interesting is that they use local regional anesthesia to numb the feeling caused by Qtenza, which is something we don't. We use Colpex and some medication only, but also in repeated treatments, a good result. Our study is on Qtenza also, has some similarities, but we tend to look somewhat more at QST. It does seem to change in our study, not in Anand's study, but it's all preliminary, and we see some sort of dichotomy with either good results or nearly no results. So genetics or the receptors already mentioned could play a role there, or related to exposure, which should be further studied. Another substance we use is lidocaine, which is a non-specific sodium channel blocker. It has a role in the pathophysiology of CRPN, so it could reduce ectopic discharges, hyperalgesia, but also modulation of the inflammatory response, which is well known for perioperative applications and also for other pain conditions. As said, the earlier study by my colleague in 9 patients showed good results after 4 weeks in 5 out of 9 patients when applying lidocaine intravenously, 1.5 milligrams per kilograms in 10 minutes, and after this in the same amount in 5 hours. So our first study in this context, and we'll further study this in the Lyon study, which was applied a few years ago. Due to different factors, but also COVID, we had a slow inclusion. But what we want to do is simultaneous administrate lidocaine or placebo with oxaliplatin. We did this in some patients, not with placebo, but lidocaine and no lidocaine in a different cycle, and measuring oxaliplatin levels, which caused the area under the curve not to change, but the Cmax of oxaliplatin did indeed change and got lower, which could be an important factor in the arising of CIPN. So we changed the Lyon study protocol before really starting to elaborate on this, because when lidocaine causes oxaliplatin maximum levels to decline, it could also be that this is in fact the way lidocaine causes that CIPN occurs less frequently. So I'm very interested in what this study will tell us about the development of CIPN and whether or not lidocaine could play a role in preventing it. And to summarize, I talked to you about recent guidelines on CIPN with little evidence on prevention except changing of the doses. Some evidence on treatment, mainly by duloxetine, small but proven effect, maybe for Qutenza and other drugs, but scarce studies. And there are some promising reinvented and new drugs to be researched. Thank you for your attention, and I hope to speak to you in the expert panel discussion later on. Thank you.
Panel later on. Before we proceed, I have one important information. We have been able to establish contact with Philippa McFarlane, who was supposed to give her talk before our break. She will give her presentation after the panel discussion later on, so please stay tuned. This also means that we will reduce the coffee break of 10 minutes to 5 minutes, and I guess that's for the best, so we do not all get so jittery from the caffeine. Our next speaker is Professor Augusto Caraceni, who is the Director of Palliative Care, Pain and Rehabilitation at Istituto Tumori in Milan, who will present on cancer pain classification results from the PRC study. Augusto.
Yes, thank you for the invitation to participate in this seminar. I'm trying to share my screen now. I think you're able to see my slides at the moment. And indeed, the content on my presentation will focus on cancer pain classification, and particularly on neuropathic pain. And this is a part of a long-term international collaboration, which includes the several centers who are already contributing to the PRC. and I would like to move into the topic immediately. So first of all, there are different causes in pain due to cancer or cancer therapies, and it is important to identify how the kind of pain we are looking at in the individual patients. The classification of cancer pain in general has been a part of a long-lasting collaboration, as I said, dating back to the first decade of the year 2000, and including international collaborations in a collaborative which was called EPCRC, funded by the European Community programs. At that time, we reviewed with several friends the classifications that were used to assess and diagnose cancer pain, and several of the aspects, both looking at the literature and looking at data from our own case series and databases to identify factors and characteristics that can be considered useful in distinguishing cancer pain features and aspects which indeed may impact on outcomes or pain intensity. By this number of observations and research, a few aspects emerges that are relevant, probably relevant to distinguish different characteristics of pain, which contribute to the variability of the pain phenomenology in individual patients and potentially in the variability on pain outcomes when therapy is initiated, depending also sometimes on the type of therapy we are looking at, that is in some cases opioid pharmacotherapy. So you see that there are already some variables associated with pain mechanism or with the variability of the individual patients or of the patient tumor interaction in producing the pain that could account for, as I said, variability in the pain phenotype. In this case, we are focusing on neuropathic pain characteristics. We have been already hearing about this type of pain in the previous presentations. So neuropathic pain, its definition, identification, diagnosis, and potential clinical impact in modifying the response of cancer patients with pain to treatment. So we are talking of pain which is due to cancer, due to advanced cancer. So we are talking of patients with palliative care needs because of a cancer which can perhaps be treated with anticanoplastic treatment, but not solved or cured. And
Augusto,
yes.
scusi, I'm sorry to interrupt you, but I don't think you are able to advance your slides. Could you please try to do that? It's a lot easier to follow for people around the world and in Norway. Did you hear me?
I hear you. Can you hear me?
Maybe you should shift to screen mode. Okay, can you try to share your screen with us?
Can you hear me?
Did you? Yes, I hear you. Can you please try to share your screen with us?
I did it. I did share the screen. Now I'm not.
And then you have to go to full mode. View on your presentation, the big view, not the list on the left-hand side.
Do you see my screen now?
No, not yet. Maybe coming up. Well, and then you need to shift. Go to the far right on the bottom, and you see the big screen. Try to push that one. Okay, now we have decided to share your screen. So just wait a few seconds. Here it is. Thank you. Sorry to interrupt you, but I think this is important for everyone to see and hear. Thank you.
It's very important, of course. I'm sorry for this technical problem. I was saying that I will try to start it again from here. We are talking about pain which is due to cancer. We are talking about pain that has a neuropathic component and how to identify neuropathic pain in a patient with cancer pain. So at this stage, we have a definition for neuropathic pain, which applies very broadly, but certainly then it identifies, as already seen in other presentations, very complex pathophysiological mechanism and clinical presentation. So we have to see how practically these characteristics of pain, that is the neuropathic component, applies in patients with pain due to cancer. For doing this, sometimes some operational definitions have been used, as you see in this slide, that are clinical features, and they do correspond at least partially to some internationally accepted definitions. One of those is the International Association for the Study of Pain algorithm, which includes criteria for making a diagnosis. An expert opinion is often used to make the diagnosis, and screening tools such as the LANS or the DN4 questionnaire are also sometimes integrated in the assessment to identify clinically relevant aspects which would qualify the pain as neuropathic. I want to show you how we applied these potential criteria in our research effort over 3 different assessments. Two of those are already data that I can share. The third is a protocol for research. In one longitudinal study over about 350 patients treated with opioids for pain, we looked at the clinical factors that can modulate analgesic impact. We are also looking at genetic factors, but these are not the objective of these presentations. So among the factors we were looking at, we looked at characteristics that could identify neuropathic pain by using the DN4 questionnaire, as I said, which is a questionnaire with a score of 4 that is a cutoff for potentially neuropathic pain. We used an expert opinion, including the IASP criteria for clinically classifying the type of pain. Breakthrough pain was assessed, by psychological distress also, and the pain etiology according to the tissue involvement by the cancer, which we also call, it is a clinical practice to call it a description into pain syndromes. And this is the description in pain syndromes. I would try to drive your attention to the first line highlighted in red at the top of this list of descriptions, which indeed classifies and is grouping all the others more detailed descriptions into 4 main tissues lesions caused by cancer involving either bone and joints or visceral tissues or soft tissues in the going from left to right in your vision, or involving lesions of the nervous tissue. In this way, we have 4 broad groups of tissue lesions due to cancer causing pain, and all the combination of them, which account to about 10 different involvement. The assessment of pain by this clinical classification has then been compared with other variables. In this case, the first analysis is just looking at how the DN4, that is the pain questionnaire classification, identifying patients with neuropathic or non-neuropathic pain, on the upper left corner, you see that by this questionnaire, 20% of patients would have been classified to have neuropathic pain, compares with the clinical classification criteria using the International Association for the Study of Pain criteria. By those criteria, we would have had a slightly different number, which is about 29% of patients having neuropathic pain. But how do they combine all together? In the graph, which cross-tabulate the DN4 diagnosis on the left with the clinical classification diagnosis in the lower, in the abscissa, you see in the red numbers that the overlap of the two criteria account for 84% of the cases, which means that indeed neuropathic pain was absent in 224 cases, according both to the questionnaire and the clinical classification, and was present in 50 cases, again, according both to the DN4 classification and the clinical classification. This means, however, that for 43 patients, neuropathic pain was absent according to DN4, and indeed was present for the clinicians using the clinical classification. And this is relevant for our overall aim of research. In particular, we also observed that this disagreement between the clinical classification and the questionnaire was more important, was more diverse in some of the pain syndromes, and particularly when the clinicians identified nervous tissues as the source, the etiology or part of the etiology of the pain, and indeed also in those cases for whom the DN4 score did not meet or did not reach the cutoff values. In another analysis of this type of clinical evaluation, we looked at the impact of some pain characteristics in the same sample of patients, looking at pain scores across 6 different points in time during the 28 days follow-up to explore the association between pain intensity, outcomes, and pain causes as classified in the pain syndrome list and adjusting for the other characteristics. To give you an idea, these are some of the trend of pain intensity according to the tissue involvement. If you follow my description, you will see that by comparing, for instance, the line of patients who have only bone tissue, only bone cancer lesions as a cause of pain, which is the blue line that you see as the second from the bottom, particularly looking at point time 2, you see the second line from the bottom is blue, and you see that that is bone pain. You can see that the other syndromic classification, the other tissue classification, indeed, they lay sometimes quite above or relatively below the line of bone pain, to take it as a comparator. In particular, when you look at the line which describes soft and nervous tissue lesions as the cause of pain, which is the green line at the top of the graph, that line tends to stay in higher level of pain for the overall treatment. The opposite is true if you look at a line which describes only soft tissue lesions, which is the bottom line in the graph, which shows that there is pain which tends to be of lower level. This is an impression we get from these lines. I showed you only part of the syndromes, not to confuse too much the vision. By using a mixed model for repeated measure statistical analysis, which is a multi-factor analysis to see which are in the relevant factors impacting on pain outcomes during the 28 days of follow-up, we can demonstrate that indeed there are factors such as breakthrough pain, which are associated with more severe pain intensity. You see it in the table, performance status, a better performance status. It is associated with better pain control. And indeed, the pain syndrome overall, the pain syndrome classification has a statistical significant impact on the outcome. And as I showed also in the graph, some of them, such as only soft tissue with lower pain intensity and the soft and nervous tissue with higher pain intensity, seems to have a particular weight into the statistical model. At this stage, we have shown that there are differences in classifying some characteristics of cancer pain in patients, in particular in comparing different methodology to classify neuropathic pain. And also the sum of these characteristics may impact on the overall pain outcome. For that reason, we are now planning a study based on this Delphi expert work, which produced a modified algorithm for classifying neuropathic pain in cancer patients based on the International Association for the Study of Pain algorithm that looks like this. We don't need to look at into detail. A study to validate this proposed algorithm, and this is the study ongoing with the centers who are participating. It will be also part of the PhD work of Morena Skodra, student in Milan and Oslo, and other centers together with the PRC are participating. This is about the scheme of the study we are going to work on, which includes the use of the algorithm, the use of patient-reported measurements of the kind of pain, and then a more detailed assessment by another researcher of a bedside neurological examination with standardized test classification according to the IASP criteria, and use of quantitative sensory testing to compare with the prospective application of the algorithm. 50 patients have been enrolled up to date in Milano, and we are moving on with the international study. Maybe somebody attending this meeting would like to participate, and they can contact me or Morena Skodra in Milano. Thank you for your attention.
Well, now there is a 5-minute coffee break, and I urge you to put some questions into the chat. After the coffee break, we'll have the expert panel, followed by the presentation from Philippa McFarlane. 5 minutes. Thank you.
I welcome you all to the PRC Congress in Aarhus in 2022. The PRC is a palliative care research center situated in Oslo and led by Professor Steinkasa.
We are very much looking forward to have this conference placed here in Aarhus and to meet again after years of online conferences.
The seminar focuses on collaboration, and we're bringing in researchers from all over the globe to enhance collaboration in palliative care research.
The conference is for everyone interested and working with palliative care, for all professionals, researchers, professionals working together with the patients in palliative care.
Aarhus University Hospital is one of the largest and most modern hospitals in Northern Europe, and we have more than 9,000 team members.
The conference will be held here in the very center of Aarhus, next to the famous art museum, the town hall, the old town, and outside Aarhus you'll find sea, the woods and the harbor.
Aarhus is a wonderful city, and I think it will be a great experience to keep the Congress in this wonderful environment and to have a great time here.
Today, Aarhus is a very young city with very many students living here. It's a vibrant, lively city with plenty of bars and restaurants and a very cozy atmosphere.
I'm always very, very excited about these congresses, and I know there's always new information, new studies, and it's also an opportunity to meet new people and especially young researchers within the field.
I look forward to meeting colleagues from all over the world to hear about new results in palliative care research, but also to share our results here from Aarhus University Hospital.
We are very much looking forward to seeing you at the PLC conference here in Aarhus.
Thank you, and welcome back to the expert panel discussion. This is our last panel, and I hope that people will join in with questions on the chat. So far, we have no questions here. Members of the chat consist of the three last speakers, Augusto, Mary, and Frank, supplemented by Per Sjögren from Denmark. I think I would like to challenge you a little bit, since we don't have any questions in the chat right now. Do you have a particular question related to Marie's study? Per?
Two things, Mary. Thanks for an excellent lecture, as usual. It was really, really interesting. And my first question is, how was insights treated in the trial? I couldn't, maybe I wasn't, had attention on it, but I was thinking about that afterwards, particularly speaking about bone pain.
Yeah.
Secondly, is it tanezumab, is it for clinical use already on this indication?
Okay, so the first question, a great question, very important. NSAIDs were excluded from the study. So patients had optimal analgesia, but minus NSAID. So that's the first thing. From the point of view of availability of tanezumab, it's not used currently in clinical practice. Most of the experience has been within clinical trials for osteoarthritis and low back pain, where the studies have been overwhelmingly positive. And the issue remains a continuous discussion with FDA about this accelerated arthritis in a subgroup of patients. So that will evolve with time. There's a number of companies looking at monoclonal antibodies to nerve growth factor, other types of drug other than tanezumab. So it's very much out there, and I think it's probably the first approach that hits on a key initiating factor of the whole cascade of, signaling and transmission.
Thank you, Mary. And since you're sort of on the line on this, there is a chat question for you. Congratulations on interesting findings on the tanezumab #1. What is the next step in this research? I'll start with that question because this is a dual question, so I'll save the next one.
Okay. The next steps would be, I think, an elaboration and an understanding of this accelerated arthritis. Although it wasn't an issue in the cancer pain studies, I think it has to be evaluated further. And is this something particular to tanezumab, or is it globally applicable to, monoclonal antibodies to nerve growth factor? And then the other part of the answer is moving forward. I think any studies looking at monoclonal antibodies to nerve growth factor, they need to be longer. They need to be appropriately powered to look at duration of response beyond 8 weeks. And I think there has to be a greater emphasis on function, on physical function. The primary endpoint, it was great that it was met at 8 weeks, looking at just pain, but certainly from the patients I personally entered into the study, the thing that impressed me quite significantly was the significant improvement in physical function. So I think moving forward, and this is a global truth for cancer pain studies in general, marrying together the function with the pain scores is really important. So I think there are a number of strands going forward. There's the basic science, there's the understanding of this small subgroup with the accelerated arthritis. Is this particular tanezumab or all monoclonal antibodies to nerve growth factor? And then there's the design of clinical studies. Physical function has to be much more integrated. They have to be appropriately powered to look, beyond 8 weeks.
This study, I would like to ask the second question by the same questionnaire here. From your knowledge on this preclinical data, could one expect better additional analgesic effect from, for instance, anti-inflammatory drugs together with tanezumab? What's your opinion on that?
I think we would need to be cautious there from the point of view of potentially increasing any side effect profile. But going back to the basic science, there's a much, much stronger anti-inflammatory action from anti-NGF drugs than there is for any NSAIDs. If you cast your mind back to that diagram I showed you, you'll see that, point number 4 was a release of anti-inflammatory agents, whether that was histamine, all the usuals. Whereas there were 5 other areas where the anti-NGF was actually acting, not just inhibiting anti-inflammatory as an NSAID would do. The retrograde transport of this complex, the receptor and the nerve growth factor, the release in the dorsal horn of the spinal cord, the dorsal root ganglion of all these other transmitters, NMDA, etc. So many. Whereas a non-steroidal will act at one point in this cascade, the anti-NGF is actually going to work at all 5 cross points in this cascade. So I would say if we can evolve the program, that would be more positive than NSAIDs. I would be cautious about using a standard non-steroidal with the nerve growth factor until we understand more about that potential interaction. But it probably is superfluous actually with the anti-nerve growth factor because of this strong action in these different, 5 areas. And I've not even gone into them in detail. The depth of the indent it makes in the cascade is very dramatic.
Okay. For Frank, we have a question here. Great talk. Should we be doing pre-treatment assessment of subclinical neuropathy to identify patients at higher risk, then potentially alter treatment, accordingly?
Thank you for that important question. I surely think that we should aim towards that goal. And identifying these patients is partially easy. We know some risk factors. So that way we could identify these patients. Potentially alter treatment is like the key factor also in preventing pain, but also in making therapy as best as possible. So I think this should be our goal, but it is difficult. First we can identify risk factors, but not a certain 100% certainty of developing this problem. So we should use DNA maybe in the future or other factors predicting this better, and then alter this treatment. Yeah.
Does anyone else in the panel want to comment on that? If not, I have a question for Augusto. Oh, Mary,
Yes.
did you want to comment?
Well, I was just going to say we have in fact looked at confocal work using a vivoscope and imaging the peripheral nerve endings at baseline in patients before they receive chemotherapy. We've also combined that with fMRI. There's 2 things. Patients who have baseline inflammation are more susceptible to peripheral neuropathy. It was a small study, but quite strong results. And from the point of view of the peripheral nerve density, those patients who at baseline had lower peripheral nerve density. So we used the vivoscope instead of doing, skin biopsies. The low peripheral nerve density was obviously associated with an increased risk of peripheral neuropathy. But it's so complex. It seems to be neuroinflammation, baseline nerve density, genetic predisposition, kinetics of how the chemotherapy drugs are handled. It's very complex, and it's not always possible, is it, to identify a baseline who's mostly at risk. But I think there is enough information, certainly from the point of view of nerve density. And what we know very simply is that the older you are, the less you have in the way of baseline peripheral nerve density, so the more likely you are to develop SIPN.
This is all true, but it remains a risk factor. So low nerve density indeed is a measurable factor, but not a very clinically usable one. So that's why we use risk factors up till now with questionnaires and whatever such. Nerve density would be a more invasive research, interesting in research, but maybe not so in the clinical practice, unfortunately.
But we do know largely who's most likely to have low nerve density. So I agree with you. It's not appropriate in clinical practice, but it does tell us the patients at higher risk based on age and sex. Yeah.
Then I would like to direct the question to Augusto. Based on the classification parameters that you have defined, Augusto, and your previous results on neuropathic pain, if you were to embark on a new clinical study, what would be your main outcomes? And what would be your main, maybe secondary outcomes? I really wouldn't know, in relation to patient-reported outcomes. Mary mentioned physical functioning as a very important parameter. What's your opinion on that?
Yes, thank you for the question. I think in general, however, pain intensity works well in the sense that we have been using average 24 hours pain intensity repetitively over time, and that with that variable, you can probably, it's the most sensitive variable for identifying changes in, what do you say? Okay. No, I thought you were asking something else. So I think that's however an ideal way. I'm sure it is important to address pain interference with function and function per se, certainly. But when applying classification or using pain outcomes in clinical trials, I think we should stick with the pain intensity, at least as a primary outcome measures. I also have a couple of questions, one for Mary and then to Frank, if you don't have any more questions from the audience. To Mary, I wanted to ask, I participated in the previous tanezumab trial when that one which was stopped because of the progressive osteoarthritis cases that initially were classified as bone necrosis. So that was a very long process of identifying indeed what was happening, etc. And then I've seen that also you mentioned 2 bone fractures in the group, and these are few cases, but since bone fractures are no more very frequent nowadays with all the treatments that we have, denosumab, bisphosphonates, I wonder if there is any interference of blocking a growth factor with other mechanism which might be protective also for neuropathies, for instance. So if the safety is still a concern in terms of this type of, and then to Frank, just to make a list, and then I will probably be quiet. To Frank, I couldn't follow very well because I didn't have the audio, but then still I would like to mention that indeed pain incidence and frequency in peripheral chemotherapy-induced neuropathy is a quite delicate variable because it is not in all patients. Sometimes dysesthesias or paresthesias are classified as pain, and we do not know if this is correct. And also there is, of course, spontaneous recovery, which is part of the course of toxic neuropathy. So I think, how do you control for those factors while looking at interventions, particularly preventive interventions? Thank you for your answers. A very good presentation, both of yours, of course. Very interesting. Thank you.
I think we have to close this session quite soon, but there are at least one more question in the chat. Olav?
Ciao, Augusto. I enjoyed your talk. Neuropathic classification is so important, but how do we balance detailed assessment in a busy clinical setting, moving the research to the clinic?
Very good question. I think that after a very long period of time since we have been classifying neuropathic cancer pain in very diverse and totally not homogeneous ways across the literature and therefore also clinical practice. I think we are trying with our research line to bring some simple classification tools that for the algorithm we are looking at includes clinical assessment and which are bedside clinical assessment, and but of course it would emphasize agreement across clinicians and researchers to use a consistent system to identify patients with cancer pain that we agree to classify as neuropathic. The fact is that on the clinical practice level, at the moment, we do not have such a homogeneity or a standard. So the standard would not be complicated, but it's more important that it is standard. It's a scholarly approach to be proven, of course, and tested, but certainly if we don't come to any clinically shared common practice, that will remain a confused area of pain management and palliative care in particular.
Thank you, Augusto. I think we'll have to move to the next speaker and shift focus. I extend my thanks to the panel. It was a little abbreviated this time. Our next speaker is Philippa McFarlane from King's College London. She will focus on or present a study on the impact of advanced care planning during COVID-19.
Good afternoon, everyone. It's a pleasure to be here today. I appreciate being squeezed in at the end of this session, so I hope your attention spans not feeling too tired after the shortened coffee break, and hopefully this will prove interesting and worth the shortened break. I'm going to be speaking today on the impact of advanced care planning on place of death during the COVID-19 pandemic, and this is a retrospective cohort analysis from Coordinate My Care, which is the largest electronic palliative care coordination system in England. So, as I'm sure we are all aware, anticipated severe illness at the start of the COVID-19 pandemic brought an increased awareness and provision of advanced care planning. However, to date, there's little research looking at what the impact of advanced care planning was on end-of-life care during the pandemic, and commonly used to evaluate as a quality indicator for end-of-life care, place of death can serve as a surrogate quality indicator. Coordinate My Care is the largest electronic palliative care coordination system in England. It's currently commissioned in London by 32 clinical commissioning groups, which serves a total population of nearly 9 million people. And just this infographic just summarizes how Coordinate My Care works. So patients can either set up their own profile individually on a platform called My CMC, or clinicians together with patients can develop their profile, and then these profiles can be updated by both clinicians and patients as preferences and wishes about care at the end of life change, and this information can be accessed by non-urgent, so mostly GP practices, and urgent care settings. So in hospitals, we have a service in England called 111, and then the ambulance service, which is 999. And the goal of this is to ensure that the right care is given by the right team in the right place that aligns with patients' preferences and wishes at the end of life. Previous analysis of Coordinate My Care has highlighted associations between factors such as do not attempt cardiopulmonary resuscitation recommendations with achieving place of death. So the aims of our work was to examine the impact of advanced care planning on place of death for people who died during the pandemic with a Coordinate My Care record. And we wanted to explore the factors that were associated with dying in a person's named preferred place of death, for these people who had a Coordinate My Care record. And our research question was, did advanced care plans and the components of advanced care plans that were contained within Coordinate My Care records impact the quality of end-of-life care, which was measured by place of death during the COVID-19 pandemic? And our hypothesis was that factors which had previously been identified as being associated with quality markers for end-of-life care, so namely death in the preferred place, would remain associated with people who died during the pandemic. So in our methods, this was a retrospective cohort analysis of Coordinate My Care records for people who were aged over 18 and who died between the 20th of March 2020 and the 5th of March 2021 that had a recorded place of death. This time frame was defined based on the UK government introducing and relaxing of lockdown rules. And the outcomes that we looked at were the socio-demographic, clinical and advanced care planning factors, which were related to achieving preferred place of death. And we applied forced logistic regression modelling to identify odds ratios for these factors. So got limited time, and I want to focus on the logistic regression modelling. So I'm just going to give a brief overview of the results. So in total, 21,963 people died with a Coordinate My Care record in our defined time frame. And of these people, 11,900 had a recorded place of death, and they were included within the regression analysis. And looking at the number of people who died each day, there were two clear peaks of deaths which coincide with the main surges of cases in the UK. So this graph shows the number of deaths by the date, and as you can see, in April, there's a peak, and this was coincided with that first wave, and then over January, December and January, there's a further peak which coincides with the second wave in the UK. So looking at the patient characteristics, most of the patients were aged over 80. Most people had a WHO performance status of 4, and this indicates that they all needed assistance with all their care needs. And 34.5% of people had a primary diagnosis of cancer, and this was the most commonly recorded diagnosis group. And looking at the engagement with advanced care planning, most people had do not attempt cardiopulmonary resuscitation recorded, and the most frequently recorded ceiling of treatment, with 34.9% of the records had what we define as treatment of reversible conditions in the home or hospice setting. And home was the highest recorded preferred place of death and also the most recorded place of death. So moving on to the factors that were associated with end-of-life care quality indicators. So this was namely preferred place of death. And we found, in line with our hypothesis, that the factors previously associated with end-of-life care quality indicators remained associated during the pandemic. And we have additionally reviewed the impact of the person's index of multiple deprivation quintile, whether there was an alignment between preferences for place of care and preferences for place of death, i.e. that they had the same care setting listed for both of those preferences. And we've also looked at the impact of urgent, which is views through by teams working with 111, which is the urgent care helpline, and the London Ambulance Service, that's 999 calls, and also non-urgent record views, which is all other record views. And just for context, if we look at actual place of death, in this graph, the pink line on the left demonstrates all the deaths in that time period. And then we've also substratified the deaths by the different wave periods that were seen in the UK. So the purple line is for the deaths that occurred between the 20th of March and the 4th of July. And again, this reflects the introduction and the relaxation of lockdown rules in the UK. The grey period is the period between lockdowns, which we've called the interwave period. And then the lighter grey period is the second wave period. So this was from the 1st of October until the 5th of March, 2021. And so we can see that home was the most commonly recorded place of death. And I think interestingly, particularly in the UK context, is that there's a sharp rise in the proportion of care home deaths in that first wave period. And looking, this graph demonstrates the model for likelihood of dying in the preferred place of death. So for those less familiar with looking at these models, the blobs represent the odds ratio, and then the lines from the blobs span the width of the 95% confidence intervals. And where the dot and the line are on the right-hand side of the red line, that indicates an increased likelihood of dying in the preferred place. And where it falls on the left-hand side of the red line, that demonstrates a reduced likelihood. And if either the dot or the confidence interval line falls across the red line, then these factors are not significant. So I'm going to talk through some of the key findings. The findings which I will be highlighting in blue coincide and correspond with previously identified findings, and then the factors which I'll identify in pink are the ones which we have newly analysed in this data. So as with previous research, we've highlighted that compared to females, males had a lower likelihood of dying in their preferred place. And compared to patients with a primary diagnosis of dementia, patients with a cardiac diagnosis also had a reduced likelihood of dying in their preferred place. Patients who had a WHO performance status of 4, so these are patients who have significant care needs and need assistance with all of their care needs, have an increased likelihood of dying in their preferred place. And we've newly looked at the impact of index of multiple deprivation, which showed that people from the most deprived areas compared to those from the least deprived areas had a lower likelihood of achieving their preferred place of death. And as identified in previous data, patients with a do not attempt cardiopulmonary resuscitation recommendation recorded on their profile had an increased likelihood of dying in the preferred place. And we've additionally looked at whether these recommendations have been discussed with family members, and this has also shown a positive influence on achieving the preferred place of death. And as previously identified, having less aggressive ceilings of treatment, so treatment of reversible causes in the home or hospice setting, or ceiling of treatment for just symptomatic treatment, compared to those with full active treatment recorded on their profile, had an increased likelihood of achieving the preferred place of death. And patients who had their preferred place of death was either a care home or a hospital had increased likelihood, which is previously identified. And we've additionally looked at whether preferred place of care and preferred place of death being the same, and how that impacts. And we've seen a positive impact there. And again, with urgent, non-urgent record views of the Coordinate My Care profile. And interestingly, urgent care record views saw a reduced likelihood in achieving preferred place of death. I just wanted to highlight the bottom half of this model. All these factors in the purple box are factors relating to advanced care planning, and also factors which are modifiable. And they've all shown to have mostly a positive impact on achieving preferred place of death. So while Someone might not be able to change their age or their deprivation score. Factors such as talking with your family about resuscitation recommendations and preferences for place of care or ceilings of treatment can have a positive impact on achieving a preferred place of death and improved quality of end-of-life care. So my conclusions are that, as discussed, these modifiable elements of advanced care planning significantly influence place of death. And as shown in times of crisis, effective advanced care planning is central to delivering high quality end-of-life care. And given the importance of these advanced care planning factors within quality indicators and quality of end-of-life care, we feel that these factors must be considered in ongoing research of end-of-life outcomes.
Thank you, Philippa, for presenting interesting results from a large study concerning palliative care, important palliative care aspects in relation to the epidemic, which is still with us, unfortunately. There is no time for questions now. I'm sorry about that. The next speaker is Bodil Jaspersen from Aarhus, Denmark, who will welcome us to the next PRC seminar, and hopefully we will be able to meet physically there. Bodil.
Yeah, thank you very much. I'm Bodil Jespersen from Aarhus University Hospital. I have just boarded a ferry. I apologize for the noise here. I have enjoyed this interesting, inspiring seminar the past 2 days. Thank you for that and all the great talks. The palliative care team in Aarhus are very honored to host the next PRC seminar. We look so much forward to welcome you in Aarhus and hope to have some great discussions, networking, and social life also. So please share our flyer, please share our little film. I wish you all a nice and wonderful weekend now, a very happy new year, and hope to see all of you in Aarhus in 22. So goodbye from the ferry here.
Goodbye and enjoy your ferry trip. Hope the sea is smooth. Stein, I call upon you to close the seminar with some final famous last words.
Thank you. And I was supposed to see the slides, but I'll see them here, so it's okay. Just relax. Thank you, Bodil. Thanks a lot. We are really looking forward to join together in Aarhus next year, and we hope that this crazy virus is under control. And I think we really need to meet and share experiences and also to present new data. And I believe that the next year's conference will primarily be based upon submitted abstracts. So all of you who wants to join together next year, meet and present results, you should already now start this weekend to prepare the analysis of the latest data and be prepared to present them in Aarhus. So just a few closing words about PRC, the way forward, 2022-2023. So what are we working on right now? I think the latest initiative was actually taken by Instituto Tomori, who is leading a joint action on networks of expertise. And we were asked to chair one work package on palliative care. The ultimate goal of joint actions, which are supported by the EU, is to create a network of palliative care integration into cancer care. So you will hear more about that. The application is under consideration and you will all be involved. And then we are working on digital patient-centered care pathways, which we have already talked about. And we are also actively involved in work together with WHO, OECI, ESMO, and EAPC. We have ongoing research projects, the PRAISE project, the MENAC project, which you heard about the other day, and we are waiting for the results from the steering group. We have the PARASTOP study, which is a randomized multi-center study, which just started in Norway. It's going to be a multi-center study. And Ørnulf Paulsen in Skien is the PI. We have the minimum data set quality of life, which is running from Brussels. And we have the algorithm study. So, and then we're having planned projects. We have the long-term opioid use study, which is chaired from Copenhagen with Per Sjøgren and his co-workers. And you heard about the multi-annum study yesterday, which is in the planning process. And as Per Sjøgren pointed out, we need new interventions in order to prevent and treat cachexia. And this is a very promising and interesting study. And then palliative care in early clinical trials. That is an initiative taken by the Milan group, Augusto Caraceni. I think the project has been a little bit sleepy during the COVID period, but I think the idea is excellent because we are asking how or what about patient-centered care and palliative care in early clinical trials, meaning that patients who have tried out most of the anti-cancer treatments. And then we have the Revolution study you heard about yesterday, and you will hear more about that from Barry Lurd and co-workers, and you will all be invited to participate. And then we have possible new projects which are under consideration, where PRC has been central. It's a No More Cachexia project, which is chaired by Vicky Barakos from Canada. This is a huge project. It's a grand challenge project. We went into the second round. We had the interviews earlier this week, and we are now waiting for the evaluation. This is a large 20 million pound project. And then PRC, together with a lot of others, which I pointed out earlier today, we submitted an application to EU, the so-called My Path project, which is about care pathways, electronic care pathways, implementation, etc., etc. And you will also be invited, if we get funding, to participate in this project. And then we are also working on networking, and we are so happy that we have a visitor from Pamplona, Spain, Amaya. We are planning new international research projects, and we are also waiting for input from you. So if we can be facilitators to plan and conduct multi-center studies, randomized studies, control studies, prospective studies, whatever design, we are very happy to hear from you. And recently we got a new collaborating center, All Ireland Institute of Hospice and Palliative Care, which we are very, very happy for. And as you have heard, the 2022 research seminar. So prepare your data and be ready. So I think that's it, Marianne. Should we say something more? We need to say a few words more.
Okay, if I need to say a few words more, I'll do that. I'll just thank everyone who's been listening. We have actually had a huge crowd spread around from Nepal to Norway to Sweden to Denmark and southern
Canada,
Northern Europe.
US, Singapore.
Yeah, anyway, we have a lot of friends around, and we have been able to build a relatively strong research collaboration. I really think so, which is fruitful for everyone who is in, and it's fruitful for recruiting new researchers into palliative care.
And we need to thank
I didn't finish.
the boys behind the screens here, and the boys working at the Norwegian Cancer Society. Without you guys, it wouldn't have been any conference at all. And this has been so professional. It has been so well planned. And Tonje, you have been the real woman behind the entire planning process, together with many others here in Oslo. So thanks a lot to you. And as I said, it's extremely professional with the director, Tonje, and with the, I'll call you the boys.
I couldn't agree more, Stein.
Behind the screen, no. And I've been in quite a few similar seminars and conferences the last year, and this has been working extremely well.
Streamlined, that's it. And actually there was one here who told us yesterday she has a brother working with digital media and things, and she got the question, are you really into a TV production? So I think that's a high quality criterion.
So
Thank you.
Next time, thanks to everyone. Thanks for listening. Next time we'll be on CNN. Have a nice weekend.